My name is Mamata Chivukula, and I'm a pathologist. My area of expertise is breast pathology, gynae pathology, and immunohistochemistry. I am a director for the breast pathology services at Sutter Healthcare. I work in the main hospital of Sutter Healthcare in Northern California, which is a Mills-Peninsula healthcare system. And I also oversee our immunohistochemistry lab. Our hospital is part of a large community practice of the Sutter Healthcare facility, which serves the Northern California area.
Great. And tell us about the historic problems or challenges around PD-L1 testing.
Great question. And there is a lot to talk about PD-L1, but I'll try to concise the years and years of what we have done with PD-L1. When we started in 2016 or 2017, when the talk about PD-L1 came, the first question I asked about the PD-L1 to an oncologist was that, a lung oncologist in our practice group, was that, what do you think about the PD-L1 immunohistochemistry? Should I bring it in-house? And his answer was, I don't care about the PD-L1, even if it's negative and the patient fits the immunotherapy requirements, then we're going to go ahead and give the immunotherapy. That was his response. Fast forward 10 years down the road, or at this point today, the oncologists are looking at PD-L1 in a quite different way, and our requests have gone up exponentially. And they look at the report very much in detail. And so, that's how we have come so far. We brought the PD-L1 in-house. We do the staining, we report it out, and, so.
So as you think about the journey and as you think about the last year, really focusing on 2020, 2021, the last 2 years, what would you say have been the biggest challenges around PD-L1 testing, as well as communicating those results back to the ordering physicians?
In the last 2 years, the challenges still the scoring system among the pathologists. And giving the results to the oncologist has been streamlined, and getting the requests for them, we have done a reflex testing right now. So anything that goes off as a lung cancer, we are ordering the PD-L1 testing in lung. So basically some of the things have gone better, but I still think that the problem is among the pathologists, what kind of a scoring system goes into place for which organ system. So we have expanded our PD-L1 testing for other organ systems as well. So that still remains the challenge.
Tell us, what have you been doing within your region to engage, to educate pathologists, as well as to get them all on the same page for consistency around PD-L1 testing?
The first thing was to bring in the PD-L1 testing in-house. We have done a pretty strong validation, both comparing with an external laboratory versus within our results as well, among the hospitals that we are affiliated with. And the third thing was to send out a study set slides among the pathologists to see the inter-observer variability among these pathologists who will be scoring the PD-L1 testing. And on top of it, we have brought in speakers to discuss with the pathologists on the challenges and everything with the PD-L1. So a lot of education from the external speakers, and also education among us, circulating the publications, and also getting a consensus by reviewing the slides and also talking about it, discussing. So those are some things that we have done to be on the same page. It's not just our hospital. We have also invited other Sutter facility pathologists to come in and talk about their challenges as well.
As you think back in perhaps the last 12 months or so, are there any specific changes or improvements around PD-L1 testing that you feel that you have made or that your region has made?
To me, the best thing out of all this education and everything is the reflex testing. Like immediately adding the PD-L1 to our immunohistochemistry panel when we make a diagnosis of lung cancer, so that we don't have to wait for the oncologist to send us the request. So shortening the time has been the best part of the PD-L1 testing. And second, dividing the cytology specimens into two parts where we can order the PD-L1 and a limited immunohistochemistry, and saving the other sample for NGS testing is something that we have done. That's been one of our greatest success in the last year.
Now, as you look to the future, what do you anticipate will change around PD-L1 testing?
A better understanding of what CPS means and how to score it among the pathologists. I know practice makes perfect, but I think every pathologist should be able to score or know about CPS. I would like to see the whole component of discussion of PD-L1 testing at a national level and see how the practices across the country are being implemented and how the pathologists are feeling. We have been talking about the PD-L1 in small pathology forums, but I think it has to be a national dialogue. One of the discussions was bringing in a speaker talking about practices and challenges of PD-L1 among different practices has been of great utility. And so larger scale at a national level would be very helpful.